Okay, I think we'll get started. Good afternoon, everyone, and welcome to our webinar today on the latest trends in home care, palliative care, and hospice. This is the November edition of the Combined Regional Training Center's monthly webinar series. My name is Kevin Riley, and I'm the training coordinator for the Marrow Regional Training Center. Audience members should have joined the session on mute with their cameras turned off. I think we're okay there. Our session today is being recorded and it'll be available for future viewing on the New York State Department of Health LMS. Hospitals should know that this session, like all RTC monthly webinars, is voucherable under the Hospital Preparedness Program. Completion certificates will be available to those who registered on the LMS, but you'll first need to complete a post-course evaluation in the LMS to get your certificate. As for marking attendance, if you don't see your full name under attendees, please provide your full name in the chat window. That'll help us take attendance. And if you're sharing a room with other participants, please notify me of that also in the chat. And for those group attendees, I'll need a group sign-in sheet emailed to me by close of business today. And I'll ask that the group sign-in sheet include the course name, your facility's name, and also today's date. For communication purposes, just keep checking the chat window for any messages or instructions. There will be an opportunity for questions and answers after each presentation. To ask a question, you can either use the hand raise feature and I'll unmute you, or you can just type your question in the chat window. So without any further ado, I think it's time to get started with our presentation today. I think it's safe to say that the critical missions of home care, palliative care, and hospice are challenging and ever evolving. So to update us on the latest in regulations and training, emergency preparedness, best practices, I have the distinct privilege today of introducing Kendall Drexler of the Hospice and Palliative Care Association of New York State. Also joining us is Andrew Koski from the Home Care Association of New York State and Kathy Fabrio from the New York State Association of Healthcare Providers. So now on to our first topic. The Hospice and Palliative Care Association of New York State is a nonprofit representing hospice and palliative care programs. They are aligned with many organizations and individuals interested in the development of quality, comprehensive, end-of-life services. The association provides advocacy for research, policy and regulations, education, public engagement, peer groups, and technical assistance. Joining us today from the Hospice and Palliative Care Association is Kendall Drexler, who is a 5-year member of the association's board of directors and currently serves as the board chair. I should say that Kendall was kind enough to sit in today for the association's CEO, Jean Chirico. Hope I pronounced that right. Ms. Drexler is a licensed master social worker. I believe I got that correct. Hopefully I did. And she's also the CEO of Hospice and Palliative Care of Shenango County. So welcome to you, Kendall. And what can you share with us today from the world of hospice and palliative care?
Well, bear with me while I attempt to share my screen. Let's see. Who knows, though? I should have checked this before. How do I present it? I'm used to using Google Slides. Does anybody know where the present is?
Go to slideshow up on the toolbar.
I think the problem is I can't see it. There we go. Thank you.
All right.
From beginning. All right. That'll be the only hitch, right? I got it out of the way for us.
There we go. Nice and early.
All right. Okay. So as Kevin said, we are a statewide member association representing hospice and palliative care providers in New York State. We are headquartered in downtown Albany on Washington Ave. And we have a 3-member staff who manage program, policy, advocacy, technical assistance to providers, state and federal legislation, communications, education, and peer groups. So to give you a little rundown of hospice in New York State, there are 40 active hospices. 38 of them are members of HIPCANES. Almost all of the hospices in New York State are not for profit. Hospice in New York State operates under a certificate of need process. So most of us are bound to provide services in the county that we provide services in. Some hospices have more than one county, but we are not allowed to go outside of our CON territory. We are bound by federal conditions of participation from CMS, and we are surveyed on behalf of the federal government by the State Department of Health. So we have federal conditions of participation and state regulations. So this is my favorite infographic to kind of describe the difference between hospice care and palliative care. So all hospice is palliative care. We are not trying to cure anything. We are trying to bring comfort to the symptoms of people's underlying diagnosis. So this model is called the integrative palliative care model, and it shows you how people conceivably should travel through the palliative care and then hospice world. So if you look here on the left, you start with the diagnosis of your life-threatening or debilitating illness or injury. At the start, you have a lot of disease-modifying treatment with maybe a little palliative care. So the palliative care piece might be helping you deal with the nausea or anxiety of your disease modifying treatment. And as your diagnosis of or life-threatening condition progresses, you should be getting less disease modifying treatment and more palliative care until eventually you're hospice appropriate. So I think that's a really good way to kind of show it. Again, all hospice care is palliative care, but there are palliative care models where the patient is not necessarily terminally ill. So that's the big difference between hospice and palliative care. Here is the CMS proposed definition of palliative care. Palliative care means patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. Palliative care throughout the continuum of illness involves addressing physical, intellectual, emotional, social, and spiritual needs, and to facilitate patient autonomy and access to information and choice. So here, because there's no official pay source for palliative care right now, Jean has put together some little boxes that kind of show different types of palliative care. So it might look like a consultation service team. Those could be the clinicians that serve on the team, a nurse practitioner, a social worker, a chaplain. There might be a dedicated inpatient palliative care unit, combined consultative service team and an inpatient unit. So maybe a patient's in the hospital with their inpatient team and a palliative care team comes in on top and gives recommendations about how to keep the patient comfortable. So again, if you just go through the boxes, it's all the different types of palliative care that operates in New York. And it probably looks different depending on what community you are providing care in. Well, there we have it. Because there's no consistency in delivery and services, there is currently only funding via physician fee schedule, grants, or CMMI initiatives. So that's kind of why there's not a lot of clarity around what exactly palliative care is. So now we move into hospice. There is a lot of clarity about what hospice is. So hospice is a patient and family center unit of care. We believe that everybody has the right to die pain-free and with dignity, and that while one person is going through the dying journey, their family is also experiencing a lot of psychosocial issues from it, and that they all need care and attention. Hospice goes with you throughout the healthcare system, and the goal is not to cure, but to promote physical comfort and spiritual and emotional healing. One of the biggest myths and misconceptions about hospice care is that we prolong or that we hasten death. So this is not true. We do not prolong life or hasten death. We allow life to take its natural course. Oop, got ahead of myself. So hospice care is entirely funded by Medicare right now in New York State. The care is provided where the patient considers their home to be. So this can include skilled nursing facilities, adult care facilities, shelters, developmental facilities, relatives' homes, wherever that patient considers their home to be. Like I said, the cost for home hospice is covered by Medicare and most other payers. We are responsible for covering all of the medications, supplies, and equipment that are related to the terminal diagnosis. We can provide acute care in facility settings for out of control symptoms. That's called a general inpatient benefit. So if a patient has a symptom that cannot be controlled in the home environment, every hospice needs to have a contract with an inpatient facility where they can provide general inpatient services to help bring that patient's pain or symptoms back in control. We also have a respite benefit for caregivers. So every hospice in New York State has to provide respite either, again, at an inpatient facility or a skilled nursing facility where hospice patients can go and live at that facility for 5 days without having their care plan interrupted while their family gets some respite. And then typically hospices follow the bereaved family of the hospice patient for 13 months or longer, depending on what the family would like. So it's really a comprehensive managed model of care that meets a lot of needs for patients and their families. So I think we covered all of this. So again, hospice as it stands right now in New York is a managed care model. So we get paid a per diem per patient per day to manage all of the needs, all of their hospice needs. We sometimes take care of dual eligible Medicaid and Medicare patients, and that saves the state co-payments and deductibles. And we already talked about GIP. So who's eligible for hospice? In general, people should have a prognosis of 6 months or less if the disease takes its normal course, or in the clinical judgment of the patient's physician. Patients do live on hospice longer than 6 months. They just need to go through a recertification process. The focus is on relief based on symptoms. We're no longer pursuing any type of treatment, and we're not using life-prolonging intervention. So Jean put some examples there for everyone. Like if you're an ALS patient, you can't be on a ventilator. If you have end-stage renal disease, you can no longer be pursuing dialysis because it's already ran its course and it's no longer giving the patient the benefit that it previously was. And all of our interventions in hospice are comfort oriented, so helping the patient and the family be as comfortable as possible. I am not going to get into this. I'm going to assume that the participants are all going to have the slides. I think this is a great slide about the difference between hospice care and palliative care, and I know you can all read. So please take a look at that at your convenience. So now we're going to jump into the emergency preparedness part. So our regulations are very similar to home care. It includes, we have to have a current patient roster that has to be up to date every day. And at minimum, it needs to contain the patient name, address, and phone number. The patient classification level, at our hospice, we call this the patient's emergency level. The patient's TAL, identification of patients who are dependent on electricity to sustain life, emergency contact telephone numbers for families or caregivers, and other specific information that may be critical to first responders. So again, because I'm an executive director of a hospice, a very rural hospice, some of the questions that we ask our patients are, do you have a generator? Have you ever lost electricity in this location before? When did that happen? How long was it out? You know, we just try to get a feel about what people have, how long they've lived in their home, and what type of emergency scenarios they've experienced in that home. So these are the triage levels. On the last slide, I called them patient classification. Again, I said at our hospice, we call it their emergency level, but it's basically a 3-level system that talks about the patient's need for service. So level 1 are really high priority. They need uninterrupted service. They need electricity so they can run their O2 or other life-sustaining equipment. They essentially would need to be evacuated if there was no electricity. Moderate priority are people who are sort of on the fence of possibly needing intervention, possibly can stay safe at home. They're the people that we kind of need to closely monitor throughout a crisis. And then level 3 are patients who are relatively stable and healthy and need the least amount of resources to be able to stay safe in their home if there was some type of, emergency. So the transportation assistance levels is what the TAL is the acronym for, and that talks about how the patient can ambulate and what they're going to need to be able to get out of their home. So are they non-ambulatory? Do they need a wheelchair, or are they ambulatory? So every single hospice patient has a TAL. We at our hospice give our patients these scores at admission, and then we update them at least every 2 weeks at our bi-weekly care planning meeting. And we try to update them whenever anything changes with the patient's status. So what are some of our challenges in hospice and palliative care emergency preparedness? So one of the things I think that tends to surprise hospital staff is our patients live independently in their homes, and even though they've been educated multiple times to always call us first, they sometimes panic and go to the ER before they call us. And sometimes it's a while before we found out that they did that. They don't tell the ER that they're a hospice patient, and so essentially they might be lost for a period of time. That is something, it's rare, but it does happen to us. Again, I mentioned that we are really, really rural, and because all of our hospice care in Chenango County is home-based, we have lost staff in the field during snowstorms where they've been stranded at a home or in an area that didn't have cell service and they couldn't move their car. So, sometimes that puts us on edge as a little hospice because we try to have a really good idea of where our clinicians are out in the field. And, there have been times that people have gotten lost. We have a large geographic and or remote area to cover. So we're not triaging all of our patients in an emergency in our facility. We're triaging them across our catchment area, which includes rural places, urban places. There could be one town or city that's really experiencing some type of emergency prep crisis. Well, other areas are not. Our staff might live in those areas that are being impacted and might not be able to get into the office. There's just a lot of moving parts when we look at hospice emergency prep, delivering care in people's homes. And again, this wasn't supposed to be COVID specific, but COVID is our current emergency that we've been living through. So some things that's brought up for us in the home care setting is we have almost no control of patients' home environment. So while hospitals can do things like limit visitors and make sure that people are following mask protocols, we ask families to do that, limit visitors, follow mask protocols, but we do not know who is in that home the other 6 days of the week that we are not present, or even the 23 other hours of the day that we're not there. So it's a very hard to control environment when we're looking at emergency preparedness for things like viral pandemics. Again, people dependent on electricity. And another thing that happens at our hospice, again, we're very rural. It goes to the last point, people are fiercely independent. So we have conversations with them about emergency prep when they're admitted. They say things like, I've lived here for 40 years. The power goes out at least once a winter. What do you mean? What am I going to do when that happens? I'm going to do nothing. I've never left before. Why would I leave now? Why are you asking me this? Like, leave me alone. It's not your problem. So I call that fiercely independent with no plans of relocating. I think that's a strengths perspective way to look at that piece. And then again, a lot of our caregivers and patients are elderly and frail with no other caregivers. So what that might look like in an emergency situation is they have a mile-long driveway with no one to plow it. So our staff need to plan on parking at the bottom of the driveway and walking up a mile-long driveway covered in snow, or, just basically going back to the hard control environments. The environments are also hard to control outside of the home. So there are some safety issues there. Opportunities for hospice to collaborate with other providers. I just have to move you guys out of the way. So our regulatory requirement, we have to have procedures to inform state and local emergency preparedness officials about homebound hospice patients. So here in Chenango County, we work really closely with our emergency management county organization to make sure that if an emergency is about to happen, we know what patients of ours on our emergency prep list are going to need to have a consult with somebody else from an emergency prep team. So one of the things that we always have to think about is, are our lines of communication and coordination clear to address emergent community patient needs? And are the staff with end-of-life care grief expertise being utilized to the best of their ability? So one thing that community preppers in general might not think about when we think about hospice and staff is that we are all trained in bereavement and grief. And a lot of times, you know, big emergency crisis type situations need people that are very proficient in working with people who have dealt with trauma and grief and loss. And I guess I can speak for hospice industry as a whole in the state. That is something that we would all be willing to help all of you with, is figuring out, perhaps after an emergency type situation, crisis situation, you know, the hospice teams could help everyone in their community deal with the grief and loss fallout from whatever the situation was. So again, Jean just suggests building palliative care teams into crisis standards of care plans, which ensures availability and implementation of comfort care for victims of an emergency event. And then there's just this one slide about COVID-19. So during the pandemic, many people have had to make medical decisions for loved ones who were unable to communicate, requiring advanced care planning and goals of care conversations, which happens to be a hospice and palliative care specialty. I will tell you that the statistic is 75% of Americans say that they want to die at home and not in a hospital. And 75% of Americans die in a hospital because they never put advanced directives in place that would allow their family to help them have a different outcome at the end of their life. So again, hospice and palliative care staff are really experts in having this type of conversation with patients and families. And we're here for you guys. We'd love to work with any of our hospital systems or care providers in our communities to make sure that our emergency prep plans are really solid and good. That's the end.
So thank you very much, Kendall. I'm going to see if our audience has any questions, but I'd like to ask a question or two myself right off the bat. You said there's about 40 members in the palliative care community across the state. Is that right?
Yes.
So at any given time, approximately how many people in the state are undergoing hospice or palliative care? Is it, and you don't have to get too specific, but I'm just curious.
I was going to say, well, that's a great
estimate.
That's a great question that I have no idea the answer, and I wouldn't even want to guesstimate, but I know Jean knows, and we could email you the answer.
Okay, I mean, yeah.
Does that sound good? I mean, I would say, you know, our hospice, again, is one of the smallest hospices in the state. We have an average daily census between 30 and 35. The hospices like out west, Rochester, Buffalo, have average daily census of 500 to 1,000. Hospices in the city have daily censuses of 3,000 to 4,000. So
it's
you
safe
know,
to say at any given day, there's thousands of people in New York undergoing hospice and palliative care.
Something that people on this call might not know is that New York State has the lowest utilization of hospice services in the entire nation. New York State is number 51 behind Washington, D.C.
That's very interesting.
So whatever our numbers are, they are lower than any other state in the nation.
Wow. And can you attribute that to anything in particular?
You know, there's been a lot of research and studies around it, and we really haven't been able to sort of pinpoint the exact reason. But as soon as we find out the exact reason, I'll be sure to let everyone know.
All right, thank you. And so how long what's the average length of care that somebody undergoes once they're designated to hospice? Is it a week, a month? Can it be 2 months? That kind of thing?
Sure. So the standard is 6 months.
Oh, okay.
People can be on longer. So not right now, but in previous years, you know, there's patients that get a cancer diagnosis and they say like, hey, I'm 85. I do not want to treat this
Right.
cancer at all. I want to go into
Right.
hospice. We care for people like that sometimes for 2 or 3 years, which is, they're always appropriate because they're not they gave up all their curative treatment. It's the lowest cost of care. It's the best way to keep them safe and comfortable while they die. But I can only speak to the data of my hospice. I think it's pretty similar across the state. In 2021, 50% of our patients have died in 30 days or less,
Wow.
which makes it really hard to provide good quality care, because the idea is you come into hospice when you're, obviously you're not healthy, but you're not in terrible shape. We have time to
Right.
get your symptoms under control. We have time to put your advanced directives in place, bring your family along. When people come in with, 14 days or less to live, the entire hospice experience looks and feels kind of like crisis care, because people weren't ready for it. They weren't expecting it. They feel like it's out of their skill set. So I would say, hospices give informationals for free. So I would say always the earlier, the better, to
Right.
just learn about what hospice can provide.
Right. Well, caring for people at the end of their life is truly noble work. So I commend you for that.
Thank you.
I have one more question. I don't see any other questions in the chat window yet. So I'm going to jump in and ask one more, and it might expose a little bit of ignorance on my behalf. But hospice care is often done in the home. So are family members sometimes trained to take on some of the care responsibilities? So can a family member, and you may have already addressed this, if you did, I apologize, but can family members learn how to run an IV pump or a ventilator, or can they be trained to give medications, those kinds of things? And
Yes. Yeah. So people can learn amazing things. People's ability to learn, I think, is only held back by like their willingness to learn, right? So my favorite example at our hospice that I love to give is we cared for a baby that was dying, was born with like a congenital birth defect, and her parents were only 18 and 19 years old, and they had no education, no resources, and they did a fabulous job.
Wow.
And I just always think, like, if they can do it, anybody with the willingness to do it can learn what they need to do to learn it.
Yeah.
So yeah, we teach, typically our patients do not have IVs and are not on ventilators.
Oh, I see. Oh,
Yeah, but we do teach people, they learn how to use oxygen, they learn how to give morphine, they learn how to turn and reposition, they learn how to care for bed sores and prevent bed sores. They learn how to give somebody a bed bath, transfer them to a wheelchair, to a commode.
right.
And hospice is very individualized. So obviously we come in, we do our assessment, we look at the skill set of everybody in the family and ask them if there's other people they could bring in to help. Everybody has a different set of resources that they're working with, and we try really hard to set up services that fit what their skill set is.
Well, it's certainly very interesting. Thank you for that very informative presentation. I do just want to see if there's any other questions in the chat window before we move on. It does not appear like there are. So I thank you again for educating us all, me especially, in your very noble field. Now it's on to the topic of home care. And for an update on the latest trends, we have a co-presentation that will be given by Andrew Koski and Kathy Fabreo. So let's start off with just a little more about our speakers and the organizations that they represent. The Home Care Association of New York State promotes the quality and accessibility of care and support in the home. Formed in 1978, they provide they provide for the development, availability, accessibility, and quality of home services. The HCA provides awareness and education programs, and they also work closely with legislators and regulatory agencies to interpret, challenge, or support policies affecting the home care profession. Joining us today from the Home Care Association of New York State is the association's Vice President for Program Policy and Services, Mr. Andrew Koski. Mr. Koski works with care providers and fiscal intermediaries on business issues and consumer services. He engages with government officials on regulatory changes. And he's also the association's Director of Emergency Preparedness. So welcome again to you, Andrew. And Andrew's co-presenter represents the New York State Association of Healthcare Providers. And this is a trade or association that represents certified home healthcare agencies and organizations that fully support the home care industry. The HCP was founded in 1974, and it represents home and community-based care providers through advocacy, information, and education. They're also supported by a network of regional chapters that build grassroots support for quality, cost-effective care. Joining us today from the New York State Association of Healthcare Providers is the association's president and CEO, Ms. Kathy Fabreo. Kathy is a certified association executive, and she also served as the executive director for the Pharmacists Society of the state of New York. So welcome to you as well, Kathy. And so now it's my pleasure to turn things over to Andrew and Kathy.
Thank you, Kevin, and thank you, Kendall. That was a great presentation. I mean, it's just so impressive to hear what you guys do. So thank you for that. Kathy and I, we represent different organizations, but we are colleagues, and we work very closely on a lot of issues. And emergency preparedness is actually one of the ones we work the closest on. So it's perfect to have both of us together. And we're actually going to be sharing the presentation. So I might do a couple of slides, then Kathy will. And Kathy, obviously, feel free to chime in even when I finish a bullet or a slide if it's something that I forgot to mention. So I'll just start off by saying that all three of the associations that are represented, HCA, HCP, and HIPCANES, we actually work with the State Department of Health under a grant for emergency preparedness. So, and it's the Office of Health Emergency Preparedness actually at the Department of Health. And we've been doing this for a number of years. And the main point of this grant, I think, is to really ensure that the needs of folks who provide hospice and home care are taken into consideration in emergency preparedness. In the past many years, emergency preparedness was really seen as a facility-based preparedness. So hospitals and then nursing homes, adult homes, assisted living. So we basically work every day to ensure that the needs of our patients are taken into consideration on all planning levels, local, county, state levels. And we work with coalitions. There are health emergency preparedness coalitions throughout the state in different regions, and we all attend those meetings and support their efforts. And I will give a shout out that there's a couple of the HEPICs, we call them, Health Emergency Preparedness Coalitions, that have really stepped up and involved home care and hospice either in separate committees or in doing separate drills. Western region, I know, did a separate drill a couple of years ago, pre-COVID. Low Hudson Valley has a very active home care work group, and there are hospice people also on that work group. And I know the Central New York in the past has also really tried to address home care needs. So a lot of good things going on out there. We also engage with key emergency preparedness partners, so local emergency managers that we mentioned early that work with hospice. They also work with home care. We also work with the health departments, emergency preparedness officials, and we meet with them and have conference calls and so on. And we have monthly meetings with the state on the grant that we have, and the state actually does provide training to us on a regular basis. And the newest thing is that both HCA and HCP, for the first time, are getting funding from the New York City Department of Health and Mental Hygiene to work on emergency preparedness. So we're just starting up that grant now, and I'm sure more to come from both of us on what we're expected to do and how it will involve both home care and hospice providers. Kathy, I think, okay, great. So we also, under this grant, provide information, education, training, and technical assistance to providers. And again, it's not just to our members. Everything we send out on emergency preparedness goals is supposed to go to all the providers in the state. We actually work with our members to ensure that they take part in any exercises or drills or surveys that the state puts on, which, as you know, is done on a regular basis. And then we collaborate with the state regulatory agencies and local offices of emergency management, really pre, during, and after declared emergencies. And then, of course, we advocate for policy development and funding related to emergency preparedness in home care and hospice.
And just to give you an overview of who is home care, what is home care, what does it look like in New York State? There's a variety of levels and types of agencies and programs here. We have a very diverse population, a very diverse geography, and our home care system reflects that. So we have certified home health agencies, which we refer to as CHAS. There are licensed home care services agencies, which we call LICSAs. There are long-term home health care programs, which we do not try to pronounce differently. And of course, there are managed long-term care plans who are the payers within the system. There's hospice programs that Kendall went through. And there are some home and community-based waiver programs that identify and provide services for either specific populations or diagnoses. One example is the TBI program, or traumatic brain injury program. That's sort of a waiver program cut out and has different rules and regulations in order to directly address that population's issues more clearly, some of the regulations that encompass the other entities that I'm listing here don't fit as well. So the state has created these programs to specifically address those issues. And then in addition, we have the Consumer Directed Personal Assistance Program, where this is a Medicaid program where the consumer or patient hires their individual aide to care for them, trains them, schedules them. And there are what are called fiscal intermediaries that are the facility or entity that oversees that program, works with that consumer, and makes sure that the rules and regulations of that entity are followed.
Kathy, maybe
Yes.
I would just, and we can do this together, just to give people about how many there are of these. And I didn't research ahead of time, so I'm probably going to come up short on this. But for the CHAS, it's probably about 120 maybe in the state. You know, we tend to think of them as the visiting nurses, historically, but obviously there's CHAS that are not just visiting nurses. You have county health departments that may be CHAS, and then a lot of standalone CHAS. The LICSs, there's probably, it's hard to give a figure because you might have one LICSA with 6 operating certificates and they're counted 6 times. So in the past, we've said there's probably about 800 LICSs in the state, but I think the state, when they've done their registration for the LICSs, have come up with even a higher figure.
Yes.
So,
and so to explain what Andy just said about the certificate, if a licensed home care services agency is providing care in 6 counties, they are required to have 6 licenses. So the number of licenses and certificates is misleading and difficult for all of us, including the state itself, to get a handle on the quantity of those agencies.
right. And the long-term care programs are programs that were very active prior to managed care. There's probably only a handful left.
Right.
They basically kept people at home who had a nursing home level of need. Managed long-term care plans, where most of the people who require Medicaid covered long-term care services, they're enrolled in those plans. And I don't even want to guess, but I would say maybe there's 20 now MLTCs. I just don't have a good figure on that, but that's all available on the State Department of Health's website. So let me just stop there.
Right. All right. And then, Kendall spoke to the hospices. The waiver programs the services are provided by these entities. It's not a separate entity unto itself. And the Consumer Directed Personal Assistance Program, the fiscal intermediaries that oversee that, are going through a process of downsizing to maybe, right now, they've identified about 68 primary FIs that will provide services. That has been a process it is currently about 600, and the state is trying to contract it down to those handful. But it's been at least a 3-year process at this point, or close to. So that is still in the works, still happening. Contracts need to be set up and signed with the state. But it does give you an idea that, there's a little bit of potential disruption in that sector of home care, and something we keep a very close eye on, because many, many patients will need to be transferred from one fiscal intermediary's responsibility to another all at once in a very short order. And this is a very big concern of ours, that everything runs smoothly, nobody falls through the cracks, and that care will be continued on a regular basis and no one will be disrupted. All right, so New York has the most comprehensive and diverse community-based care system, home and community-based care system in the country. And that really does speak to what New York State is. We are a very large, geographically, culturally diverse state, and our system reflects that. It's very broad-based, it encompasses a wide array of both health or clinical services as well as support services. And this is wonderful in that we get to supply this support to our citizens, but it also complicates matters. And we'll get into more of that as we explain to you how some of the pandemic and other emergency waivers and such were rolled out. There's so many different layers to the system. One or more layers can easily be forgotten when things are being changed and updated depending on the emergency. So some of the care that we provide is post-acute. We also do rehabilitative work, daily supports, and we supply care for the complex long-term medically needy individuals. And it is not just elderly, as you will often hear referenced, but it's also adults and children. A home care agency can be sponsored or operated by a freestanding entity, such as a privately owned agency or the visiting nurses model. And then hospitals also have created home care entities themselves, as well as nursing homes and many of, and the counties. So there's a lot of different models here available in New York State, also making this very diverse. So the providers and agencies of home care are state and federally certified or state licensed. So for example, the Licensed Home Care Services Agency is unique to New York. It is licensed by the state of New York, and it is not an entity recognized by the federal government. So as the federal government makes changes in emergencies, et cetera, the state then has to act again to determine how is that going to apply that to the state licensed home care services agencies. Just adds another layer of thought and process into our system, that this is what Andy and I and our colleagues keep track of and pepper the Department of Health with over how does this now affect this group? How does this affect this group? Because it is a constant reminder and battle to let everyone know of the different layers in home care that it affects. And so for you to keep in mind is that over the state of New York, there are hundreds of thousands of cases annually being taken care of in home care. And for us, working in this emergency preparedness infrastructure and grant program, which began it as a hospital-based system, I think we all have to take a step back and realize there's more people being cared for in the home at any given day, potentially in that local hospital that you might be thinking about in an emergency. And that is something we're very grateful that home care is becoming more and more apparent and identified as part of the system in an emergency. Because it's important that we get the support we need to continue to provide care for those patients. And we can also act as entities that can take on people being released from hospitals or facilities as well.
And Kathy, I would just say that, just like what Kendall said, that the hospices, are governed by the federal conditions of participation. The certified home health agencies are also, and as Kathy mentioned, it's very hard to understand, you have the CHAs are governed by the federal conditions of participation. And that's where you have all the emergency, all the emergency stuff that they have to implement and follow. And then you have the state LICSs, and it's really tough to sometimes to decipher, well, the CHA has to do this, the LICSA doesn't, but the LICSA contracts with the CHA, so maybe that does affect them in a certain way. And that's something we're constantly working on, and it takes up a lot of our time, and it's something we'll continue to do going forward. Sorry, Kathy.
No, it's a very good point. So some of the clients that we are taking care of across the spectrum are children and adults of all ages. So it's individuals with public health needs, medical fragility, developmental disabilities. We have post-surgical patients needing assistance for short-term, possibly with wound care, or just that transition back to home after hospital discharge. We have patients that are on ventilators, that we have IVs, pain control, et cetera, as well as new mothers and infants. And then there are individuals who need assistance with activities of daily living just to remain in their homes. So they're all maintained with skilled supervision. We provide the support services, potentially home modification, and even equipment for these individuals to remain in their home. And as Kendall referred, 75% want to pass in their home. The percentage is even higher that they want to age in their home. That people are not saying, I'm the one that wants to go to the nursing home. They want to stay at home. And so we provide the services that allow that to happen, if at all possible, through a wide variety of services and for a very wide variety of individuals. So here are some of the services that we provide. The professional services or clinical services provided by licensed individuals. We employ a lot of RNs and therapists. We have personal care services, which is the assistance with daily living, helping with ambulation, toileting, dressing, et cetera. And those are primarily provided by either home health aides or personal care aides. We have housekeeping, we have assistance with errands and appointments, and we also incorporate telehealth services into the programs. We have the ability for the RN to call in and work with the patient, the individual, and if the home health aide is there, to assist and assure that information is being shared and that the issues are being discussed and understood and then implemented. And then some of the supportive services, which I mentioned on the previous slide, are home adaptations, delivered meals, social daycare, the medical supplies, et cetera. So we're trying to provide all of the different components of care and allowing these individuals to remain in the home through these services. I think we're going back to you, Andy, on this slide.
Sure. So just as hospice is required, Kendall eloquently mentioned, home care agencies are also required by state and federal regulations to establish and maintain emergency preparedness plans. In fact, if you look at Title 10, which is the state regulations, it requires the agency's governing authority to ensure the development of a written emergency plan, which is current and includes procedures to be followed to assure healthcare needs of patients continue to be met in emergencies which interfere with delivery of services and orientation of all employees to their responsibilities in carrying out such a plan. So it's right up front, governing authority for the agencies themselves. So the rules focus on 4 core elements of emergency preparedness for providers. Again, this should not be a surprise to those folks who work for home care and hospice, and of course, for those folks who represent other sectors. Agencies are required to do risk assessment and planning. They're supposed to do a hazard vulnerability assessment at least once a year. It's an all hazards approach to figure out what hazards they face, to rate them, and then how are they going to address them. With the Lower Hudson Valley HEPIC, the home care work group has probably spent maybe 4 or 5 meetings, believe it or not, discussing a hazard vulnerability assessment, and folks talking about every type of hazard they face, and how do they rate that, and again, how do they incorporate emergency preparedness to address them. Policies and procedures based on the emergency plan have to be developed and retained by the agency. The agency has to have a communications plan of how they're going to communicate with staff, with families, with local emergency preparedness officials, during emergencies. And then they have to do training of staff on a regular basis and new employees, and testing their employees' understanding of emergency preparedness, and also exercises. And this is all under the federal requirements, but the state also does require it. The plan must be reviewed every 2 years. And again, like I mentioned, the agencies are responsible to collaborate with their local and regional healthcare providers and county emergency preparedness providers in their plan development. And some of the counties actually have sample plans that they've put together they can share. It's on their website. So there's lots of assistance out there for folks who need some assistance putting together their own plan. In addition, and this is specified in the guidance put out by the state, known as the Dear Administrator letters, DALs, where they have to basically the home care provider has to have, and I'm going to skip around a little bit, but a patient roster. So obviously a list of their patients, updated list every day, the patient's name, contact information, family members, caregivers, and so on. That has to be kept, readily available. Emergency contacts 24/7, again, family members, but also in the community. The person is electricity dependent, a number for the National Grid or Con Edison or whoever else. Numbers for the local fire department, health department, police department. That all has to be kept and readily available by the agency. Of course, a call down list of agency staff, because they're going to have to call their staff pre-emergency to tell them what's going on, what they're going to do, and keep in touch with them. Of course, the updated list of community contacts and partners, which we mentioned some of them before, collaborating with local emergency management. And again, that can vary depending upon how big your county is. If you're in New York City, obviously it's a much bigger organization than if you're in a very small county, but it's important that you do collaborate with them. And I think during COVID, a lot of our members for the first time did collaborate with the local emergency management. Health commerce system communications, you have to make sure that your communications directory is updated, and you have to check the HCS daily. I probably check it every few hours because there's constantly stuff being posted there. The state constantly sends out IHANS notifications to people. But you have to be in the health commerce system directory to make sure you get them. And then during the emergencies, you're notified sometimes by phone, on your cell phone about something that's going on. You then get an email, and I should say multiple phone calls and emails about the emergency. And even though it could be a hassle to people, it's very helpful because it keeps you in touch with what's going on. And I mentioned before that agencies have to participate regularly in drills and exercises. And one of our jobs, as the associations with the state, is to publicize these drills and exercises and make sure that all the providers participate in them, but also to make sure that the drills and exercises are relevant to home care providers and hospice providers. And then, like Kendall said, you have to prioritize your patients, level 1, level 2, and number 3. And then what their transportation assistance levels are. All it has to be tracked, again, daily. And a lot of the surveys the state sends out, either during disasters or not, will request this information also. So another reason why you need to have this. Okay, and I think, Kathy, am I doing this one?
I thought you were, but
Okay.
I could be
Don't
mistaken.
want to step on your toes here.
Nope.
Okay. So a lot of this is very similar. Kendall really put it very well. Just like hospice, home care can serve a small area or very large rural area. we had one member from the North Country who some of the patients had to be served by boat. People who could only be reached by a boat. So I always think of that story of the person on the boat going out to deliver the care. And you know, and also in home care, every patient is at home, and every home can be different. As you mentioned, Kendall, you don't know who's going to be in the home on one day. You don't know what they're going to bring into the home. You don't know whether they're wearing the mask, whether they're having protective gear, whether they've been vaccinated, whether or not there's, you know, what type of relationship they have with the patient. So in effect, we say that, you know, every situation is different. And, you know, that's why it's really hard, I think, for home care to incorporate all the principles that every other sector does, because it really becomes very complex for home care. And again, we mentioned that we can help provide some staff to decompress patients from facilities. A lot of the exercises the state has conducted have been around that issue. And the bereavement counseling that Kendall mentioned, I think, is so incredibly important and something we really need to keep in mind.
And so home care, I hope you understand, is essential. And yet we often struggle with during an emergency because we are not a well understood industry, and we're not the first people that are thought of in an emergency. And so sometimes what happens is we have difficulty accessing our patients, whether the zone is restricted because of a weather event, or as in COVID, a lot of, was all these stay-at-home orders. So one of the first things our organizations had to do was, are we labeled essential workers, and are we in that category? Can we get a letter agreeing and getting that into the hands of every employee? So if they're out on the street trying to get to a patient and are stopped, that they can provide some sort of documentation that they are an essential worker and that they need to get through. So that then leads to also the same situation of access to fuel at times. Some of our regulatory impediments to care and management in emergency conditions sometimes take a little longer than other entities to get addressed. And there's a lack of federal, state, or other financing for the preparedness, for the response, or the recovery. And we're here today to help provide education and comprehension of home care by the rest of the community, understanding what we do, how we do it, and how we all need to work together. Home care has very significant dependency on communications and utilities. Most homes do not have ventilators, or I'm sorry, generators. So if there's power outages, et cetera, we have a different level of concern than, say, a hospital who may have a whole they'll have a whole backup system for their utilities. Home care does not. And something to understand is, if the home care provider cannot supply someone in that home, that means 100% of that person's care team doesn't show up. In facilities, that's a very different dynamic when there's others to provide backup, or at least a watchful eye. In home care, there's one person there at a time providing this care, typically. So it is a very significant emergency for those individuals getting care at home.
No doubt.
Yeah. So we do have some very unique situations. We do have patient and family fears with allowing someone in the home, resistance to that in general. I can take care of myself. Loved that fiercely independent phrase you used, Kendall. We see it all the time. And sometimes the family or the individual does not want to accept the healthcare directives provided in the home. They're, ruler of the roost. So what they say goes, and may be less likely to listen to what's being advised. And there's always family dynamics to deal with. Is there that one individual that is not in agreement that this person needs care, or with what care is being provided? And you have to walk that fine line and be very diplomatic in the family dynamics of working in that home. We also experienced during COVID, the significant inability to get PPE, and working through the state. We were not the top priorities to be getting any of the state's supply. And I will, give a shout out to several of the counties that really stepped up and worked with our home care members to make sure they had PPE supplied from the county level. We all know the PPE system was really a challenge initially. It lingered on for home care for a little longer than for others. And I will say that the New York City Department of Health and Mental Hygiene provided PPE for home care for, my gosh, Andy, what was it, like 12 weeks? And our organizations helped to make sure that got distributed on a weekly basis to all of the city's home care providers. And we've been experiencing challenges with workforce for quite some time. They're only been exacerbated by this state of emergency. And this includes nurses, it includes the home health aides and the personal care aides, it includes the therapists, particularly with the aides who are making what is typically a little bit more than minimum wage. As minimum wage has been raised, they're finding that they are making the same as someone working in a restaurant or retail. Now with shortages in workforce, they may be making less because Target and all of those retailers can provide bonuses. They can provide higher levels of pay by raising their prices. We are very dependent upon Medicaid and Medicare payment to provide these services, and we don't control that reimbursement rate. So it just slices the financial dollar thinner and thinner in home care. And we've been had very difficult time paying workers what they deserve to be paid, as the whole infrastructure and work system seem to be going through a turbulent time. We've also been challenged in training aides in the traditional in-person training program structure with COVID, with social distancing and requirements very early on that the training programs shut down. Then when they were able to start back up because of social distancing, the class sizes were far smaller than normal. And we worked, both HCA and ourselves worked with the Department of Health on a hybrid training program to help alleviate that, but it's been a very slow rollout, a lot of hoops to jump through to be able to provide that program, and hasn't been the solution that we had hoped for. And so in addition, the personal professional impact on personnel with these emergency issues also meant a loss of staff as well as patients. We did have a lot of patients not wanting to let folks into their homes during COVID, or at least until we understood COVID better and how to avoid transmission. So now and throughout the pandemic, as I'm sure many of you were, we were providing survey and reporting to DOH different data and information. We have found, I'm not sure in your sector, but we have found that we've been allowed limited access to that comprehensive data, which would help us help our members if we knew more about where the problem spots were, either geographically or operationally, but that it's not been possible to get that data into our hands. There's been a significant increase in unreimbursed administrative expenses, the PPE we talked about, but the whole vaccine process, educating their staffs. These are individual phone calls people are making to their staffs to talk about getting the vaccine, to help schedule the vaccine, keeping track of, do you have the vaccine? This workforce doesn't typically report to a facility where you can gather a group of them and talk to them. You're talking one-on-one. You're talking about phone trees that are just incredible, and a lot of time spent on personal interaction with their workforces. We've had a lot of ongoing regulatory requirements, and we've got little input on that policy making, and really had to fight for every bit of regulatory relief we received, which always seemed to be a day late and a dollar short. And frequently, because of the complexities of the home care system, when guidance is given, we have to then come back to the Department of Health and ask for clarification. Does this mean LICSs? Does this mean FIs? Does this mean everyone? Does this, And then frequently they have to go back into legal and determine, does it or doesn't it? Everything was happening quickly. We understand that people were hard pressed to get out everything they could get out, but the complexity of our system really came to light when guidance was released. And there is a lack of state funding for this industry. Everyone wants to be at home. It's a more cost-efficient care system than the facilities, but yet the funding doesn't follow that thought process. Some of the added burdens we had specific to COVID were always fighting to get access to the testing, to the PPE, to the vaccines, and really have had no dedicated funding for COVID support outside of federal funding, the American Relief Plan. And just before Thanksgiving, we learned of some federal match dollars through the Medicaid program that is going to be begin to be released in 2022, but they're limiting it to the top 1/3 of LICSs. So what that happens then is other components of the home care industry don't get that funding. That means the CHAs, the hospices, and then even within the LICSs, some of the specialty and niche providers will not be receiving that support. There is a lot of conversation at the federal level about home care, and we're hopeful that there will be more funding coming, and there'll be more structural changes coming, and the state will embrace the home care industry in a way they haven't been able to be before. But we will have to be at the table to make sure that occurs. But the Department of Health has made it clear that they find the number of providers in home care is difficult for them to manage. And many of the policies that they're creating today are intended to contract the industry. And similar, we talked about that FI contraction going from 600 down to 68. They want to do that in other segments. And we are just really concerned about what that's going to do to patient transitions and care if not done thoughtfully and wisely. I'll pass that back to you, Andy.
Okay, so we want to end, I think, on a very positive note. So I'll talk about some of the opportunities that have come out of really the COVID, era, and that continue. So we have a lot of collaboration going on with home care providers and their hospitals and with physician groups. Again, lots of things going on, taking care of patients who have high needs, following these patients in the community. And so a lot of good collaborations going on, and we hope the state will support them. You also have advanced collaborations with local Office of Emergency Management. What I didn't put up here was, home care. We, as Kathy mentioned, we had a fight to be recognized as essential when it came to getting tests, COVID tests. It's hard to even think of that now, because for a while you could go anywhere and get a COVID test. And we forget how hard it was to get home care providers to get their workers tested. And same thing with the vaccine. We had a fight to make sure that home care workers were considered essential workers to be able to get the vaccine. But in addition to that, we have members who stepped up to the plate and actually provided the tests themselves. And we had members who provided the COVID vaccine for folks who couldn't get out. We had some members who were on their own, went into the community and actually set up sites, under the aegis of either the Department of Health or the New York City, and did mass vaccinations. So I think they really did an incredible job, and that's something important to highlight. It improved during the, really the beginning of COVID. You had the agencies had to figure out a way to communicate daily with staff, with patients, and their community partners. And so we've heard a lot of stories of what the agencies had to do. They were never used to communicating on such a frequent basis, but they had to do it because things were constantly changing. As Kathy mentioned, the state was coming out with guidance, sometimes twice a week, 3 times a week. And once we could decipher it and get that information out to providers, they then had to get that out to their staff. And I still get calls today from people saying, do we still have to do temperature checks of our staff? Do our staff still have to wear PPE in the home care settings? This is an ongoing process. Maximizing technology. A lot of agencies for the first time use telehealth and remote monitoring to improve the efficiency and safety of both their staff and patients. You had agencies who never worked in telehealth and now are providing a lot of telehealth services. Unfortunately, the state has really never provided funding outside of a Medicaid, originally providing Medicaid payments for telehealth, but during COVID, the agencies had to basically, purchase the material themselves, not the material, purchase the devices themselves. And now the state is really wanting to get back to people doing in-person visits. Online training options, we were hopeful initially when the state, we worked with them on this hybrid training model, but as Kathy mentioned, it's become pretty complicated. And people, as Kathy mentioned, people are not showing up for these training programs, whether they're in person or even the hybrid. It's still going to take a lot of education to reorient people to working in the home again, and to be able to use some of these options. There were virtual approaches to workforce recruitment, to opening cases, to onboarding, and a lot of this is carried over, past the heat of COVID. Procedures. You have agencies sharing business innovations. They've had to update their protocols for infection control and care management. They've really had to explore new ways to conduct their business. And I mentioned before, they expanded the COVID testing and vaccine administration. And then really getting their staff ready for dealing with this emergency that has, of course, drawn on for over a year. And then also offering recognition of their staff. I think agencies have done an incredible job of recognizing staff in many ways they never would have thought of before, because they really are the true heroes of this whole pandemic. And then continued opportunities for advocacy, to communicate with policymakers. We're constantly on the phone with Department of Health to improve the regulatory guidance, to understand better what it is, to get things out on a more timely basis, and then to continue to educate the community, and our healthcare partners. So I'm going to stop right here. I see we've actually gone later than I thought we would go, Kevin. So I think that's a good sign, though.
That's all right. It looks like our audience is hanging in there. So,
Okay. So Kathy, do you want to add anything, and then we can go to some questions, maybe?
I think we can go right to questions, Andy.
Okay.
well, home care is truly a dynamic and challenging field for sure. And I'm looking in the chat window to see if there are any questions. I'm also being mindful of the time. It doesn't appear like there are any questions, but I'll keep an eye on it. In the meantime, I'll just ask two very quick questions, one of each of you. Andrew, it seems like Title 10 mandates a very comprehensive whole community approach when it comes to emergency preparedness, risk assessments, policies, training, testing, and so on and so forth. So is it safe to say that if your region encounters a blizzard, that the local town and county emergency operations centers maintain an accurate registry of who's out there, not just the patients, but also the care providers, and that the state itself is monitoring who's out there, who might be snowbound through the health commerce system? Is that accurate?
Well, I would say to the home care providers and hospice providers is that it's really up to them to make sure that they establish a relationship with their local counties so that they can.
So the onus is on them.
Right. I would say it's on them. I mean, it's really on both, but this can, changes daily. Your patient roster can change daily. So it's important that folks establish these local linkages so they can update, the utility companies, so they know who is, who's dependent upon electricity. And then just one quick small correction. Title 10 is the regulations. A lot of them much more in-depth stuff, about the patient call downs and the rosters. That's in guidance issued by the State Department of Health. So you wouldn't find that in the Department of Health Title 10. So I don't want folks to be spending hours looking in Title 10 for that, but there is guidance out there.
But Title 10 is a state code, correct?
Yes.
I mean, the federal government has a Title 10, but that's something dealing with the military and that sort of thing.
Okay.
So,
Kathy, do you want to add anything to that?
Sure.
Kathy, I do have a quick, actually, I'm looking at the chat window, and James is telling us that the Department of Aging may have a contribution.
Yeah, no, I think and I hate to, and I would say not may have a contribution, but definitely has a contribution, and I should have included that. But obviously, I shouldn't say obviously, home care and hospice providers should also be in touch with their local office for the aging. In fact, we have, providers that actually provide services under the ISEP program. But obviously, the counties provide lots of other services, case management, transportation, meals, and really, that's the home care providers should be aware of that, so they work together with them, pre-emergency, but then also during an emergency, they may want to reach out to them to see how they can continue to work.
Right.
Thank you, James, on that.
Yeah, and James is also adding that the Department of Aging helps out with locating households in needs during winter storms. So yes, thank you very much, James. And I don't see any other questions, so I'm going to sneak a quick one in for you, Kathy. There's definitely a connection to or between home care and the federal government in terms of funding and licensing and those kinds of things. So I imagine that there's a lot of commonality between the states, maybe not a lot of variation in state programs. So if somebody is trained and licensed and credentialed in New York and they want to move to Ohio and get a job in healthcare in Ohio or Nebraska, is it safe to say that they can pretty readily find employment? Is there reciprocity between the states vis-a-vis credentialing?
Well, that's a complicated question because each state sets its own criteria for credentialing and or licensing. And that incoming state is going to be the one to determine whether or not they're going to accept the credentials of another state. However, I will say that New York is probably one of the more stringent states in its credentialing and licensing of any profession.
Yeah.
Coming back from the pharmacy world, it was always they were at the top of the state's state's requirements, and so other states are more likely to accept those credentials and licensing. New York is a little bit tougher on others coming from other states and into our state. However, they did relax a lot of that during the emergency.
Yeah, they have to adapt. So, okay.
I just wanted to mention something really quick. Kathy jogged my memory. Hospices have also been filling out a HERD survey. At the beginning of the pandemic, it was 7 days a week, down to 3 days a week. We just lobbied and got it changed to 1 time a week. We have also not seen any state level data about what the HERDS is showing, which I think is disappointing from a HIPCANES level. Again, like Kathy said, like we can't really, the association can't do much to help out the members if they don't see the raw data that the state is seeing that is indicating problems. But one of the things that we are asked to talk about in the HERDS every Tuesday that we fill it out is what is our surge capacity. So, I just think it's important for hospitals to know that home care and hospice are being asked on a weekly basis, what is your surge capacity and how many patients can you take to help, with the flow of patients. So we also are feeding that information to the state.
And that may become more important in the coming weeks.
Exactly.
Well, as someone who fills out a hospital HERD survey every day, I certainly take an interest in that. It's certainly a valuable reporting system.
Yes.
So, I don't see any other questions in the chat, and we really are running close on the time. So I think we can wrap it up safely. And let me just say in closing that I'd like to thank our esteemed panelists and each and every one who tuned in this afternoon. I apologize for running a little bit long. The work you all do is truly honorable work, and it's a personal privilege to me to share your company today. I'd like to just remind everyone who registered in the LMS to please fill out a course evaluation so I can cut you a certificate of attendance. And let me also encourage all of you to register for the December RTC webinar, which will be conducted on December 7th from 10 a.m. till noon. The topic of that session is going to be emergency planning and preparedness for persons with disabilities and access and functional needs. So let me just ask my speakers if they have anything else to add before we close out. If not, then I would just like to wish you all a very safe and happy holiday season. And thank you again for tuning in today. Have a good day.
Thank you.
Thank you, Kevin, for having us.
Yes.
Yes, thank you.
It was a pleasure.